We have our session, Simulated Patients in Public Health, that's presented by Dr. Gina Wesley. And Dr. Wesley has her master's and PhD in health communication. She has 24 years directing standardized patient programs, 10 years with National Center for Biomedical Research and Training, U.S. Homeland Security, and specializes in innovation in health professions education. All right, I will turn it over to you, Dr. Wesley.
Thank you so much, Cassandra. Let me just pull this up here. Okay, great. So good afternoon, everyone. I am Gina Wesley with the College of Medicine here at the University of Kentucky in beautiful Lexington, Kentucky. I am very mindful of the fact that I am the last speaker and that you are all eager to go off to your dinners and your families and your evening's entertainment. So I won't linger, but I do hope you enjoy this presentation. Also, I teach medical students on a daily basis. So if you have questions, please don't hesitate to interrupt me because I'm used to being interrupted. Okay, let's get started. I thought I would start actually by telling you very briefly how I got involved working with departments of public health and agencies of public health across the country. I'd been hired at the University of Louisville to direct their brand new standardized patient program. This was back in 2000. And I had been working a lot with some friends over in public health. And one day they called me up, and we'd been having the anthrax letter attacks. They called me up. They knew that I'd been simulating some things like elder abuse, domestic violence, and things like that in my program. And they asked if I might be able to simulate cutaneous anthrax. And that was what started this presentation. And what followed as a result were millions of dollars in grants and contracts that I received either on my own through the program as a PI or in conjunction with the School of Public Health and Information Science at the University of Louisville. I'd like to point out that all of the grants and contracts I'm sharing with you right now came to be during just a 6-year period from 2002 to 2008. So let's start off with what are standardized patients. I'm very curious, have any of you ever heard of standardized patients before? Just raise a hand. No, well, that's not surprising because unless you're a fan of Seinfeld and you caught his now infamous gonorrhea episode, you may not have heard of standardized patients. So SPs, as we call them, are individuals that I hire and train to do a couple of different things. The first thing is that they portray cases for our students, whether they're nursing, medical, dental, pharmacy, and now public health students. They portray cases. They're exceedingly well trained to be very accurate in their portrayal, to follow a standardized script for what's going on with their case. And so they portray these cases. And the idea is, because we're set in a clinical setting here in my little clinic at UK, is that when students enter the room, they feel like they're in an actual doctor's office. And the expectation is that they will, first of all, take a medical history, and then second of all, perform a physical exam. And so that's what the medical and nursing students primarily focus on. Once they've done that, they then provide a differential diagnosis. They talk about what this might be, some possible avenues for treatment, and the standardized patients, while they're trained to portray the case, They're also trained to act as assessors. So they assess the student or grade the student on their performance. We develop a checklist of things that are most important for the case and for the communication that we want students to engage in when they're interacting with their patients in our clinic. And so once the student leaves the room, the patients then fill out a checklist to let us know how the student performed. And so standardized patients are doing a couple of really big tasks. The first, acting as a patient and remembering all these details about their case. And then second of all, once the student leaves, they sit up on their exam table, they go to the computer and they fill out a checklist to assess the student's performance. Both large tasks, of course. This program here at UK is used extensively throughout all 4 years of medical student education curricula, a number of medical residency programs, and at many critical points in nursing, physician associate programs, our pharmacy program, and we will soon be beginning to work with the College of Public Health and the College of Law here at UK, in addition to working with a number of outside clients, but more on that in just a moment. So how does this fit in? It's a pretty logical use of an important assessment and training tool in medicine and nursing, but how does this fit in with public health? First and foremost, we all know that public health has traditionally followed sort of a pedagogical guide for how we do training. However, adults have specific learning needs to make our trainings more effective. So the pedagogical approach of a didactic presentation, such as I'm doing today, is not nearly as effective as when we can get adult learning theory involved. Adult learning theory tells us that adults have certain needs in order to learn. They bring a lot of skills and attitudes and experiences to the table. They love problem solving. They need to work where they feel safe and accepted and respected. They need feedback on the spot rather than days or weeks or months later. And they need to feel respected and like they have choices in what's going on during the training session that day. The literature tells us about standardized patients that when we introduce them to adult learners are far more likely to remember more information that we're training them on and to remember that information for a much longer period of time. We're able to help sharpen their critical thinking skills and their communication skills. That's something standardized patients do really well, or simulated patients do really well. We can assess their decision-making skills. We can provide them with that oh so valuable feedback in the moment, in real time. We're able to assess and train at the same time. And as I said, learners report that they remember things much, much longer when they get to work with standardized patients. Some critical elements to making for a successful patient simulation activity include working closely with your subject matter experts in public health and medicine and nursing, whatever group it is that you're working with that day, that you're training that day. We need subject matter experts to help us form those checklists that we use to assess, to help us put together the curriculum that they want addressed. Also important is the extent to which my simulated patients are trained. And so their training is rigorous. They go through hours and hours of training for every single event, and they're tested to assure that they're able to not only accurately portray their cases, but also accurately assess their learners. We also bring to the table expertise in something called moulage. And moulage is when we use makeup, stage makeup typically, to simulate diseases, lesions, injuries, things of this sort. We do that very, very realistically. In fact, all of the moulage that you're going to see, some of which is a little tough to look at. So there's your warning. All of the moulage that you're going to see in this presentation has been thoroughly vetted by on-site clinicians, by the CDC itself, and by exposure to a number of different practices. And so we've been able to validate the work we're doing in a number of different ways. The final critical element is you must have a passion for public health. And we certainly bring that in aces and spades. So I was telling you a little bit earlier about how this all got started with the request from the School of Public Health at the University of Louisville to create some cutaneous anthrax lesions because they wanted to include those in some trainings they were going to be doing for clinicians. So if you recall, our first anthrax letters were mostly, if not exclusively, east of the Mississippi, where anthrax is not endemic to the soil. And so our clinicians on the eastern side of the country who saw our very first cases of cutaneous anthrax. Oh, wait, I'm sorry, I'm noticing there is, oh, you love the Seinfeld episode. I'm so glad. Yeah, that's a good one. If you haven't, check out Seinfeld on YouTube and look for standardized patients or gonorrhea. I think you'll get a kick out of it. So anyway, so we were seeing in the early stages, our Eastern U.S. physicians and nurses were seeing lesions that actually look like this middle stage. What happens with cutaneous anthrax is there are three primary stages. This is the first stage. And I always tell people I would rub some Benadryl on this. So it looks like a little contact dermatitis, maybe a mosquito bite. It's not itchy though, but it's a little red and there might be a slight induration in the center. About a week later, you start getting this lesion. And this is what people started going to their family doctors for in New York City and in other places that had received the anthrax letters and people were exposed. And what do you think the physicians and nurse practitioners, public health workers were diagnosing here? Do you remember? I'm watching the chat. You feel free to unmute yourself and let me know if you remember. So they thought this was a bug bite and they prescribed some steroids to help the bug bite because it takes away the itching, it helps with inflammation, and it gets a chance to heal. Steroids, unfortunately, are not effective on cutaneous anthrax. And so this lesion quickly developed into one that looked like this about a week later. And so in this area and in this area, what you're seeing is necrotic tissue, dead tissue. And if left alone, this lesion will continue to grow larger and larger. Fortunately, when people return to their doctors or their hospitals with this kind of lesion, the doctors went, okay, so this is not our ordinary bug bite. We need to figure out what's going on here. And that's when they started culturing and they started figuring out, oh, these look like railroad cars. This organism looks like blocks of railroad cars. Yep, that in fact is anthrax. So what I would do in preparing this simulation for public health trainings at the time, is I would do these 3 simulations on this woman's arm, and on the other arm, I would put a spider bite. And this was a way that we could train our learners how to tell the difference, differentiate between impetigo. Yeah, absolutely, Yolanda. How we could how we can tell the difference between the evolution of a spider bite versus the presentation of cutaneous anthrax. So people really liked that. They were very eager. And when we had standardized patients come into the trainings, we were able to pass out gloves and people could actually palpate these lesions. They could talk to my simulated patient and get a thorough history about the evolution of what we were seeing. And so she was able to present to them as if she had been a letter opener or she had been a mail room worker who had been exposed to some of the anthrax letter debris. And so that's really what got us started with all of this. Let me see. Any questions?
I have a question.
Good.
This is so the evolution of the reaction to the body, of course. So this is to assume that anthrax doesn't evolve on the body, like grow bigger or welt like a bug bite would. It might start like a little pinpoint, but it might welt up. That's the evolution of the bite and how your own body reacts to that. So are we to say that anthrax wouldn't evolve in any way, shape or form, that it would stay the same? Or we can't say, look, it didn't get any bigger, it didn't welt, it didn't, we can't draw a little permanent marker around it and it didn't go outside the lines. Is that to say that anthrax wouldn't cause that on a normal body, wouldn't react to that? It would stay the same?
No, actually, anthrax evolves like this naturally on everyone. So unless you have a genetic combination that makes you immune, and I've never heard of anyone like that, but I suppose it's a possibility. So where we find anthrax living in the wild, in the soil, out in the western half of the United States, they call anthrax wool sorters disease because farmers in different parts of the world where anthrax grows naturally in the soil, farmers show up with these lesions every once in a while. And so that's why if this had happened out west, we probably would have known what it was much sooner, because those physicians and nurses and public health workers would have recognized it probably, having seen it before. But on the East Coast, we hadn't seen it. But yeah, this is the natural evolution of anthrax. What we saw was weaponized. And so it may have moved faster. It may have taken less exposure to fewer microns dosage. But this is just what it looks like when you contract it in the wild as well. Does that answer your question, Crystal?
Yes, thank you.
Absolutely. Great question. Any other questions? Okay, you ready for the next one? Let's do that. Oh, this is just a picture of me. So one of the things we did when we were doing this work is we went out to the, back when the gaseous diffusion plant was still in operation out in Paducah, Kentucky. I love to tell this story. I actually got to ride in a Black Hawk helicopter from Frankfurt to Paducah and back that day for this exercise because the Kentucky Department for Homeland Security was out there. But I'm sitting out here in the weeds and running some mannequins for the U.S. Army's 31st CST to come and take care of these folks. So you can't see them in the photos, but there's some anthrax lesions on these patients. All right, this is a fun one. So this is a viral hemorrhagic fever like Ebola. This one's not hard to spot as problematic like the anthrax lesions were. We had a lot of fun putting this together. The contact lenses to simulate subscleral hemorrhaging I was able to speak to someone in Hollywood. I know that sounds goofy, but it's true. And he's one of the guys that makes contact lenses for all the horror movies out there. And so I called him up and I said, look, this is what we're wanting to simulate. Can you make me like 6 pairs of these contact lenses? And he got it right the first time. The color of the blood, everything was absolutely beautiful. So then we chipped into the simulation the hemorrhaging around the eyes, the jaw, and hemorrhaging from the nose and mouth. So we hemorrhage when we have a viral hemorrhagic fever like Ebola, we hemorrhage from our mucous membranes and around joints and areas where we touch a lot. And that's why you see this person hemorrhaging. I actually also figured out how to get a spontaneous nosebleed with this, which really freaked a lot of people out because they didn't expect a spontaneous bleed to happen. And you just take a tiny piece of sponge, you soak it in that fake blood, and you stick it up the nose and you wait for gravity to take effect, and it will pull that blood right down. It's highly effective. Let me see. Say if someone's lying on the ground or they're sitting on a exam table and they get a spontaneous nosebleed, it definitely takes people aback. So we've used this to train in lots of contexts, lots of different types of professionals. In particular, the Louisville, Kentucky Homicide Detective Squad came out to do training on all of our bioterrorism type stuff and emerging infectious disease simulations. And so the message for them was all that bleeds is not necessarily trauma. So their first guess was this is someone who's a victim of domestic violence or perhaps been in a car accident, motor vehicle accident, something like this. And so it gave us the opportunity to talk to them about a lot of things like what personal protective equipment do you need to be wearing when you interact with someone who looks like this. We also debuted this at the Dallas-Fort Worth International Airport. They have airports are required to have a large triennial exercise, full capacity exercise every 3 years. And we were the invited guests to come out to Dallas one year, and I took about 40 people with me, and we filled a field with injured and dying patients, and one of them had a viral hemorrhagic fever. And so we tested the entire city of Dallas, not just the airport, on their response. And that was very interesting. Even more interesting was that just a couple of years later, we had our first cases of Ebola, and they were in fact sent to Dallas, if you recall. Here's another day where we were working. This is one of my simulated patients on the ground. Vince is a stunt actor person, and I would hire him specifically to challenge law enforcement. So you see a lot of weapons on these folks. There's a firefighter on the left, but the other gentlemen are law enforcement, and he was trained to challenge them. We had the wonderful opportunity to use Ford Motor Company's executive jet on this day, and we helped train the Joint Emergency Services Unit in Louisville, Kentucky, on what do you do when someone on the aircraft is very sick? How do you handle that? How do you deplane the sick individual? Do you do that first, or do you deplane everyone else on the aircraft first? And what do you do with a plane full of people who have been exposed to something that's contagious? Do we release them into the community? If we don't release them into the community, what are we going to do with them? And so this is one of the best kinds of exercises where we raised a lot of questions that are still being discussed nationally. So here's a couple of photos from that Dallas-Fort Worth Airport exercise I told you about. This is Deanna lying on the ground on the right. and she's one of my standardized patients. You will see her in a photo here in just a moment. But it was a very warm day that day. And not only did we have to fight the heat, we also had fire ants on the ground. If you know anything about Dallas, Texas, you know fire ants abound, and they promised me they were spraying the field for ants a couple days before, but they didn't get them all. And our moulage is based in glucose. So poor Deanna was a real trooper that day. Took her out for dinner, and all the other SPs too that night. Thanked them for their hard work. Here's an exercise we did in Somerset, Kentucky back in 2005. This was a really neat exercise in that it was a chemical exposure. So you can see there were gunshot wounds as well. In the upper left corner, that's Chet. Chet was wearing earplugs because firearms were being used with simunition to take down the bad guy in the exercise. We did this in a local elementary school, and it was a long, hard day of work. We learned, for example, this is Jackie here, that when you give someone like Jackie gunshot wounds and you lay them on the ground all day, those gunshot wounds are going to stick to the floor by the end of the day. So that made for an interesting end of day activity. It was, pulling Jackie away from the school floor in the hallway. So here's Jackie again, and this has so far been the biggest, most important exercise that my simulated patients and I have conducted. This was a red cell exercise. It was classified at the time. It's no longer classified, so I can share this. And I was working with Dr. David Runge, who at the time, this is the mid-2000s, was the medical director of U.S. Homeland Security. A couple of colleagues and I put together a proposal, and we sent it to Dr. Runge. We proposed this exercise, and he funded it. So what we did for this exercise is, anybody want to guess what this is? Oh, Lauren, we'll have to talk about Dallas. I'm reading the chat. Okay. So no guesses on what you're seeing here? This is what day 3 smallpox looks like. So smallpox has an interesting course of events in how it manifests clinically. The first couple of days with smallpox, the patient is completely laid out on their back. They have a high fever, 104, 105. They are completely not ambulatory because of the back pain and the fever. And most patients would have stayed at home, would have laid low because they're just too sick. They may go to their hospitals, of course. The chances that hospitals today would recognize smallpox in its earliest stages are slim to none. Because despite this exercise, we still haven't had a national rollout of this kind of training. I'm working on that though. So smallpox first emerges in the mouth, on the buccal mucosa, the tongue, the roof of the mouth, and then it begins to spread outward to the lips and the face. On day 3 of smallpox, which is what this is, on day 3, a person's temperature goes down to maybe 101, 102, so it's manageable. And they become ambulatory for a short period of time, somewhere between 12 and 24 hours, they're ambulatory, before they get much sicker very quickly. So our fear, and the reason we propose this exercise, is that when people become ambulatory during day 3, they may choose, if they have self-inoculated or self-infected with smallpox, and we know that there are vials of smallpox missing since the Soviet Union bloc broke up. We worry that if someone's willing to strap a vest to their chest and explode it, they're also likely, if they can get their hands on smallpox, to do something like this. And this would be far more devastating than just a single person setting off a bomb in a restaurant or a crowded place. This would close ports across the planet if we had a single case of smallpox pop up. It's just that contagious, and it's just that deadly. So what we did with the exercise is I had a plane ticket, Jackie had a plane ticket, and my colleague, Dr. Bill Smock from Louisville, Kentucky, who is an ER doc and also a SWAT doc. So he works with Louisville Metro Police Department as well as University Hospital. So the three of us went on this trip together. Jackie had a seat separate from me and Bill. And we went in at Louisville International and we flew to Cincinnati, to CVG, where we hung out for a couple of hours in the Delta Sky Room, or whatever that room is called. We took her photograph there, standing at the window with the Delta aircraft in the background. And then we boarded a flight for Washington, D.C. We went into DCA, or Reagan National Airport. When Bill checked in at Louisville, he had to check in his weapon because he carries a weapon when he flies. And that's a big rigmarole, as it should be, as I'm sure you know. And they also informed him that on his flight going into DC, there would be 2 U.S. air marshals. And so when we got to Cincinnati and we were about to board to go to Washington, Bill spoke with these 2 air marshals because he's a deputy marshal. They always communicate with each other so they know where they're sitting on the aircraft, these kinds of things. And so it came time to board the aircraft. The U.S. air marshals were among the first to board, and they sat across the aisle from each other in first class. So Jackie walked right between them onto the aircraft. Bill and I were also seated back in coach, near Jackie, but not with her. What we found was that no one stopped her, no one questioned her, no one did anything to interfere with her boarding a flight. No one even asked her to put on a mask, which, by the way, we can't force U.S. citizens to put a mask on an airplane. Now, COVID changed that for a short while, but with oncoming infectious diseases, as they begin to emerge again, as they most certainly will, we currently do not have legislation in this country that will allow, say, a Custom and Border Protection agent or a TSA agent or a flight attendant to require someone who looks febrile and who has a cough or a rash to put on a mask. That's not legal in this country. And that was another thing that we talked a lot about with Dr. Rungate. So we learned some important things, the most important of which was our airlines, our FAA folks are not prepared for something like this. We certainly saw them struggle during COVID, but for something even more catastrophic like this, they're woefully unprepared, and there's no training being provided to them currently along these lines. Again, I'm working on that, but it takes a village. So I would love your help. As a differential for day 3 smallpox, I also created this chickenpox simulation. So I could train people to know the difference between smallpox and how it emerges on the body, and chickenpox and how it emerges on the body. This young man was a U.S. Army member, and back in the late 2000s, he flew into Kentucky from Afghanistan with the military. He's a U.S. citizen. He was raging with fever, in a lot of pain, and very uncomfortable when he got to Kentucky, and he was delivered to Ireland Hospital. And Ireland Hospital, he told the folks at that hospital that he had had chickenpox as a child. They got his mother on the phone, and she confirmed that he had, in fact, had chickenpox as a child. So they were very scared that, in fact, this might be smallpox. Again, current physicians, nurses, etc., are not being trained to recognize the difference between a smallpox or chickenpox, or, to my knowledge, any form of bioterrorism versus their differentials. So this gentleman was placed on a helicopter and flown up to University Hospital in Louisville, Kentucky, where my colleague Bill Smock checked him out and immediately recognized chickenpox. You can tell the difference between chickenpox and smallpox, excuse me. Do you see how these lesions on Jackie's face are all one size, one shape? They're all at the same point in their growth and evolution. So compare that to this chickenpox. And just like my simulation of chickenpox, you see the crop of lesions is asynchronous. So we've got scabby areas next to new forming lesions, next to pustules, right? And that's one primary way to tell the difference between chickenpox and smallpox. And so because we had had this training and delivered these trainings, we were able to diagnose this gentleman as having a really terrible case of chickenpox. We're not sure why he had it a second time, but he did. And we're able to provide him the support he needed. So he healed up, he got better, and went on his merry way. So here's my question for you. If you saw this woman in an airport or at the ball game or in the grocery store, what would you think she had? What is this? Smallpox, chickenpox, contact dermatitis? What do you think this is? Yes, Sachina, you're right. The last natural outbreak occurred in 1949. We did have a case as late as 1979, though, in the world. And the World Health Organization declared smallpox eradicated in 1980. However, there are vials of smallpox kept alive, frozen but alive, at the CDC in Atlanta and in Moscow. As I said, when the Soviet bloc broke apart, some of the vials in Moscow disappeared. We don't know who has them. We don't know where they are. And that's part of what makes this a very valid concern. It's a low likelihood, high risk scenario, right? This is actually, good job, Yolanda and Kendra. Yeah, this is actually smallpox again. So one of the things that we know is super important that we do when we do these simulations is that we do them using people of all different skin colors. Because what looks like a red, painful rash on me, for someone who has a darker skin tone, it may not show any redness at all. It may look quite different. And so we always make sure we do these simulations on a number of people who are able to show us what it looks like for different skin tones. So this is also a day 3 smallpox. What would you do if you ran into her in the grocery, at the game, on the plane? As public health people, as workers in healthcare, what responsibility do we have when we see something like this? Any thoughts? Well, the position that we've taken is that as healthcare providers, healthcare workers, public health workers, we have a responsibility to say something when we see something like this. That puts us in some very awkward positions. Not nearly so awkward as trying to handle a smallpox outbreak, in which case awkward doesn't begin to describe. So asking someone, how long have you had this breakout? Do you feel okay? Can I get something for you? Just asking questions, showing compassion, but concern also, because you never know who is sitting next to you at these events. To wrap up, and then we can do some Q&A, I just thought I'd share with you a few of the client lists for the bioterrorism work that I've done. Okay, so what do we do next with this? How many trainings do you conduct now regarding everything from autism to any really special patient scenarios, to how we prepare our public health workers, our child protective workers to walk into situations? How do we prepare them to recognize this? This model is demonstrated to be highly effective for a longer period of time than a simple didactic presentation would be. So if you start to think just about the many ways you could apply this, it's going to start to blow your mind. And it's the potentials are enormous. And I am willing, eager, ready, you name it, to help you with that. We have enormous capacity here and the standardized patient program in the College of Medicine at UK. And part of why I was hired here last April was to bring these programs to the University of Kentucky. We don't only want to take this to UK and our neighbors and the region, we want to take this nationwide. And so your input would be so helpful to me. And I am also willing, to take your calls, your emails, to offer suggestions, to, do what it takes to help integrate this training model into some of the work that you're doing, if that's something you think would be helpful. All right, so here's my contact info. Please feel free to contact me at my office. I'm great for email. I return calls. Call me on my cell if that's more convenient, especially if it's after hours or weekends. Call my cell. My one and only child is off to college now, so call me anytime. I have the time to work with you. Okay.
Well, thank you, Dr. Wesley, for such an informative presentation. We do have a question from John in the chat. How well do you think our public health system is ready for another pandemic?
I think, John, if we went back into another influenza or SARS type infection, we're not excellent. We're decently prepared. We're still going to run out of supplies. We're still not going to have masks or enough oxygen or beds or abilities to intubate and keep people on breathing machines because there just aren't enough in our country. So we're not very well prepared, despite what we've just been through. When it comes to a smallpox, or let's say a botulinum toxin being released into the food supply, something like that, we are woefully inadequately supplied and prepared So most of you will probably know about the national stockpile out there. I think it's called by a different name. So I'm dating myself when I talk about the strategic national stockpile, but you know what I'm talking about. And you probably are also very familiar with what's stockpiled in your local hospital or your city. It won't be enough, just as it wasn't enough for COVID. It won't be enough when these things happen. And just as the anthrax attacks came, something else will be around the corner. We know that.
Another question, Dr. Wesley. Is there a duty to warn by calling someone to report suspicions?
I believe so. I believe so. We learned this from COVID. We simply can't sit back and wait to see what happens because it spreads too quickly. It takes too many lives, and not just the lives of our public, whom we are charged to protect, but also the lives of our healthcare and public health workers, their families. So I believe that we are required or obligated to make those phone calls.
Absolutely.
Any other questions? Please, please, please don't hesitate to reach out. If you can't tell, I love this stuff. And I would love to hear your ideas for how you might be able to use simulated patients. And don't think just in terms of patients. Think about any kind of training that you're doing with adult learners, how we can do that more effectively.
Wonderful.
Thank you guys so much for coming today.
Thank you. Thank you, Dr. Wesley, again. Thank you.
It's been
Let's
a
see if we
joy.
have anything in the chat.
Thanks, Cassandra.
Yes. And so, everyone, this is the conclusion of our TCOM Cloud Gathering conference on behalf of the University of Kentucky TCOM team. We look forward to seeing you again next year in person, possibly at our 20th annual TCOM conference in San Francisco, or you can join us at our cloud gathering virtually. In the meantime, though, feel free to join our TCOM community by subscribing to our TCOM channel. The information is in the chat, and we will love for you to join and stay connected. We have great things, great information on there about this work. And if there's not anything else, just thank you for all the work you do on behalf of others. Thank you so much.